we have ourselves two good limbs here, right? Long bone, two bones, bunch of little bones, yeah, they're bigger, but still, bunch of little bones, and then digits. The design is almost exactly the same. The difference is going to be in the size, right? Now I have contralateral elements. No! Our patella. That would be a bad time. The greater trochanter, the greater tubercle. Okay, we're looking at the greater tubercle. Both of these, the big ones, all right? The greater ones are on the lateral sides of the body. I'm holding these as they would be on a person, okay? So greater trochanter on the lateral side. Greater tubercle. There's greater T's at the tops, kinda, of both of the long bones, all right? I don't know, I worked out, I thought about this, and the only thing I could come up with was tube. YouTube has funny videos, you're on the humerus. That's the best I got for you. But tubes with the humerus. Right? YouTube has funny cat videos. That's the best I got. Versus trochanter. I don't have any way to remember trochanter. So tro what? I don't know. Tro doesn't really seem to apply, but trochanter. You've palpated this enough where I hope that's kind of locked in. But greater tubercle, lesser tubercle. Greater trochanter, aha, lesser trochanter. So two T things, a greater and a lesser, at the top portions, kind of. The femur has more structure to it. It has this neck and head that's separate from these. The tubercles, because the humerus is much more delicate and mobile, they're right actually by the joint direct. Okay, but you could palpate these as a way of identifying particular muscles, all right? This groove here between those tubercles is where a predominant biceps tendon runs. And so when people get bursitis and issues here on the front of their shoulder, this can be an important element of understanding kind of like just where these things are. We wouldn't be pushing ground directly on these, but I may need to find them and then move a little bit inferior to just know that I'm on the right thing and affecting a muscle from its tendon toward the belly, trying to help something that's more specific to if there was an injury at the attachment versus the belly. A lot of issues occur where there's these overlaps of the joints. So, all right, now we come down here, and an easier thing to reflect on is that once we get to these portions, these rounded elements on either side, then we're going to have condyles and epicondyles, all right? Epicondyle, meaning slightly above. You're going to palpate epicondyles. Condyles are a bit more inferior, but you will feel the epicondyles on either one of these very easily. So with these, you don't have as much differences. You have to remember that whole anterior orientation of the palm for it to be in true anatomical position. Remembering that here, when you palpate that, lateral versus medial epicondyle, it's going to be the same way down here, the bottom of the femur. So lateral, medial epicondyles. We have a patella, which that one usually you've heard plenty of, kneecap, but patella. That one's just floating around in there. It has no helper. This does not have a direct bone-to-bone interaction. It is floating in more a element of connective tissue. I'll come back around to that one. But if I'm creating parallels, which is the main goal here, like look, you have two ball and socket joints, right? Ball and socket, both with some larger bony landmarks, greater and lesser T's, tubercle, trochanters. Then we have the long bone part. That's where you have a bunch of your red bone marrow and all that good stuff, and these long bones. Then you're in your epicondyles and condyles, epicondyles and condyles. Then we have like the actual, what we think of as like the elbow, the point of the elbow or the knee, right? The kneecap, right? Patella, that's its own floaty thing, but we could create a comparison between it and the olecranon. So if you're looking at your pictures, you're gonna see there, that section of the ulna is the olecranon. And that's where when you're applying pressure, you have to be braver about being close to your olecranon, maybe not right on the point, but be really close to it so that you're using a little bit more of this part of your forearm to get a bit more pressure for people that need it, right? Okay, but now we're just to the long bones. Now we're to an ulna, which is kind of the main bone of the elbow. Look, the radius doesn't have a whole lot to do with the elbow joint proper. There's gonna be some muscles that cross bridge and what have you, but in terms of a bone-to-bone interaction, the elbow is the humerus and the ulna. Here, look at the same thing. We have an interaction really just between two bones, which is gonna be the femur and the tibia. And it's right here on top of the tibia. That's where a meniscus lives. There used to be a knee floating around, but that's okay. I have this one. So here's all the ligaments put in place for a knee. And we have that patella floating around in this deep connective tissue. This portion of that is the tendon that attaches into your quadriceps muscles. So patellar tendon, people will call this the tendon, but it's technically a patellar ligament because it is a bone to bone, right? If you look at these charts, that's what you'll see. You'll see the anterior quadriceps muscles turn into a tendon, attach onto the patella, and then at the inferior portion of the patella, there's another bit of that that attaches onto the tibial tuberosity, which is what in this bone model, it's pretty much sitting right on top of. Right here, see that bony bump? That's a tibial tuberosity. Not named too bad because at least it's just on the tibia, right? But we have those. Comparing the two, again, if we follow these all the way down, so the tibia, then if we follow that all the way down to the ankle joint, there's going to be a big bony projection that you can feel on the medial side of your ankle. That's that big bony bump, and that's the end of the tibia. And that is called the medial malleolus. This is where the names sadly do kind of suck. But medial malleolus, over here, if we follow that ulna down, it actually gets smaller, is the really weird thing about the arm bones, is that the ulna is big at the elbow, more about the elbow. The radius is tiny and doesn't really do a whole lot with the elbow. It gets big and is more about the wrist. The leg, it's all tibia. It's predominantly tibia. But then you have at least a big section of the fibula right here. But these projections, this one, again, the arm stuff's always gonna be smaller and more delicate, but there's a little hook on this side, a little hook on this side, and then there's a much bigger hook right here, huge by comparison. So I mean, the fibula at least has like a more predominant bony landmark, even down here at the ankle. But that's the lateral portion that you're feeling when you feel these ankle bones, quote unquote, right? It's the base of the inferior portions of the tibia and the fibula. And the name for those is the medial malleolus, lateral malleolus. They pair up structurally to these bony bumps, which their purpose is attachments of stuff, ligaments, tendons. Medial styloid, lateral styloid. So styloid with malleolus, I can't help you too much there, but styloids versus malleoli. Hopefully, my main goal here is more for you to reflect on how, with the bones of the limbs, there's really more correlations. And rather than you having to have each part memorized, knowing you have these key elements in both to kind of pay attention to, right? You can kind of just like go, well, the femur is at least similar to the humerus, and you may not remember what these are, but you know that there is a bony landmark projection to feel here. There's a bony landmark thing to feel and identify here. And then getting a better sense of, once we get down here, like this is a great example of the structure of this. Look how that lateral malleoli comes down so much more than the medial one, okay? That's why ankle sprains tend to be inversion. Structurally, we're built to have less mobility and more stability on the lateral side of our ankle, and structurally that's just how it is. So you have ligaments here and all that, but if somebody, so it makes it easier for us to turn our ankles in like this. That means if this is loose, or if we're playing a sport and it happens once and we really badly lengthen these, it's hard to ever get those to fully shorten again if the sprain was bad enough. So lateral ankle injuries occur, and the place where that tear tends to happen is somewhere around this lateral malleolus, the end of the femur. So all I have to do to maybe help that is to think about the muscles that attach on the femur, sorry, the fibula, God, the fibula, attach onto the fibula and maybe cross over and affect this. And maybe also the stuff on the opposite side that balances that out. But the example of why the structure has purpose, but then what does that asymmetrical structure tend to cause? And that is why we'll see ankle injuries predominantly be like that. All right. Then you're just to tarsals and carpals, and we're not overwhelming that point, okay? Visually, what I want you to start with is a understanding of how much space the carpal bones actually take up, okay? Look how small that is. It's incredibly tiny. When we use our palms, we want to be starting our pressure through these because they're closer to the long bones, and pressure delivery of everything. If everything starts going through this long bone, right? My body weight, my strength, everything is starting coming through this, then I want that force to translate as directly all the way through so that I'm getting as much efficient pressure as possible. That's why when we're applying pressure, it's going to be more like this. The arm will be oriented just like that, and I will be applying pressure predominantly with this section of my ulna. And I don't want to be right on the tip because I don't want to bruise anybody, but I want the pressure from coming down through the humerus to translate into, I want to use that energy as much as possible. If we're too far over here, then I'm going to be fighting on a teeter-totter, okay? Here at the palm, let me straighten out, and if my pressure is too far forward into the middle of the hand, same thing. One, I'm going to pinch the extensor side of my wrist, and it's going to be just less efficient for me. So on some level, think about as you're even applying pressure, you got all these tiny little bones. They're pretty stable, like they just slide around. There's usually not a lot of cases where injuries occur here too bad. Occasionally a fall where somebody lands. Like that's a kind of this pisiform little thing. But then when you pass this around, I just want you to kind of stare at those shapes, but even these kind of get like a sense of them, right? You have your 1, 2, 3, 4, 5, 6, 7, 8. Yeah, 1, 2, 3. Yes, so acronyms go a long way. But 8 here. compared to your big giant tarsal bones. So this one is part of that, right? Your actual heel bone. Let me make sure we're on a page that makes sense now. Let's flip ourselves to flippity flip to, what is that? 220, page 220. All right, tarsal bones. Here we will talk a little bit about the names of the structures. Is that?
These aren't the same on here.
Oh, they aren't? Yeah, no, yeah, just scroll till you see a femur
Okay.
and a foot. Let me move our patella out of the way. Now, looking at this and this, what I initially want you to get a sense of is like what we call the heel, which is this big giant. I mean, look how big that is by comparison, right? It does not actually contact the tibia and fibula. It is this one on top of it. Okay, there's a muscle right here sitting on top of it. That is what actually makes up the ankle joint. So your ankle joint comprises tibia, fibula, and the talus. So the talus sits right there on top, and it sits right on top of calcaneus, right? This is why when I talk about kind of grabbing a hold of the heel and giving it a little bit of a movement back and forth, these bones, just like these bones, they don't move in the same way that these big hinge joints and bone socket joints do. They have play, but they're more like they need to be able to slide back and forth on each other a little bit. Not too much. Like there's always a delicate balance between stability and mobility. These do need to be more stable, but they also need a little bit of movement, otherwise things get jammed and then tissue gets uncomfortable and there's a symptom. But we have that. We have this talus sitting right on top of this. And then on the lateral side of the foot, the pinky side of the foot, look how there's one bone attaching to these long bones. 1 for 2. And the pinky toe even has its own big, like, it's the proximal chunk. And I call it the, I think it should have a more specific name. So like we'll call it the proximal tuberosity, but you'll never get tested on that being a specific thing. But it's an important element. A lot of specific muscles attached there. Some muscles come down all the way down and attach onto it. There's some intrinsic muscles. Intrinsic means they just are like in one place. So the intrinsic muscles of the hand, they're only on the hand. They don't go to the wrist. Intrinsic muscles of the foot, they're only on the foot. They don't go to the ankle. But this is a big concavity where some issues can occur. So getting a hold of this half, it's not a half, it's a, it's a 2/5 of the foot. We have what meets our heel bone, calcaneus, to 1 cuboid, and then that attaches to the metatarsals of the 4th and 5th phalanges. So phalanges means toes or fingers, okay? But on that lateral side of the foot, very structural, and it's a case where like when you feel the foot, it's gonna be kind of harder over here. The arch of the foot is softer, has more flexibility, all that stuff. People that kind of tend to walk maybe a little bit more on the outsides of their feet, it's a natural thing to turn to in the event that you have instability or weakness or immobility of structures of the foot. So then you have 2 things that happen for people. They start using this part of their foot a little bit more for impact, but they're also going to turn their foot inward into inversion, and guess what? They're probably going to be more likely to sprain their ankle. Little implications like that. The way to kind of maintenance this, and we'll get to where you can be more precise here, It's just while we're working, this idea of grabbing a hold of a person's heel, but realizing what you're really doing is you're grabbing a hold of their calcaneus. And there's just soft tissue. There's like small layers of soft tissue and some tendinous attachments right here. It's really just going to be calluses and skin and a little bit of adipose. It's very lymphatic and fluid driven down here too. There's plexuses of like when we lift our foot up, it kind of fills a little bit with fluid, and we step back down, it's supposed to squeeze it like a sponge, etc. But if we grab a hold of this, we move it back and forth, I can move the entire ankle joint around, but I also can think a little bit about, if I make sure this calcaneus moves, maybe that'll help the ankle joint as well as help the rest of these structures. Okay. 2/5 of the foot, very structural. And that half of the foot, really two bones. Two bones meeting your pinky toe and your ring toe. The 5th metatarsal, 4th metatarsal. Over here, look how many more you have on the medial arch side of the foot, right? The medial arch side of the foot, the talus meets the navicular, and that's really what makes the initial part of the arch. When people have flat feet, if anybody's had gone and worked with podiatrists or anything like that, or gotten orthotics, things like that, there's something called a navicular drop. Now that can be a destabilization of the ligaments here, but one way to think about it is if somebody has flat feet, they don't really have much of an arch, it's like this whole section has collapsed in. If you look at it, it should be kind of a cave, right? Should fold over and have a cave that you could put your hand underneath if somebody was standing there. Over here, it's going to be flat, except for this little section, but it's very much bone against the ground. Over here, the arch shouldn't be very directly collapsing inward and contacting the ground. And it's one of the reasons, and the implications of what that does to the ankle joint, etc. That's why typically flat-footed people are told they shouldn't run or do athletics as much. That being said, I've seen the flattest feet in the world be a professional athlete. So don't ever take the idea that just because a textbook or somebody says that a flat-footed person can't run efficiently doesn't necessarily make it true, right? People can find a way. But the arch of the foot is that. It goes from this talus bone that's sitting on top of calcaneus. The calcaneus doesn't actually influence that arch or the rest of your toes. The calcaneus is just there to kind of have impact, and the main bone, the main other tarsal bone it connects to, is over on the lateral side. Here we have this navicular bone, and then 3 cuneiforms, one for each individual additional toe. And whether hand or foot, the thumb or the big toe is going to be number 1. Number 1. So first metatarsal, first metacarpal, first phalange, first phalange, second metacarpal, second phalange, second metacarpal, second phalange. So 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. But that arch side, an extra bone that matches up kind of, sort of, with this, and then 3 individual bones for each of the toes. And just as you're mobilizing and working here, having an impression of that. When the foot is turned, one of the big advantages of sideline, when the foot is on its set here where you have the medial section more available, when you're applying forces here, you're going to apply them predominantly to that 3/5 half. And if you're closer to the heel, then hey, you're maybe influencing this weird little junction. When you come right there in the middle, maybe you're influencing that part of the arch where that navicular bone is, and you go a little bit closer to the toes. Now you're here, and you would feel that because you have this one section right up here, all the way up. So you're going to be all the way up here in the sense of like working on the foot. Right here, when people talk about the ball of the foot, there's these extra, really big projections here at the end, at the distal end of your first metatarsal. Now that creates a groove for the tendons that come through there. But it will be uncomfortable for you to push there. In terms of like working on the foot, usually you don't want to push hard right there. And these they're called sesamoid bones, like little sesame seeds. So sesamoid bones, or smashing right directly into the heel, because you're just going to be pushing skin and other soft tissue into bone. Right? There isn't really a muscle right here. We want to pull that away maybe if somebody has some issues, but the muscles are housed right here. Person laying on their side, I apply forces, and I'm just thorough. I'm getting that whole medial arch side. Person's laying the other side. We work, and we apply forces more this way. See how we're influencing that section more precisely. And it's a case where even if you were stuck having to do the footwork in prone and supine, still try to create this division, this 3/5 to 2/5 division down that section of the foot, and recognize that one side is more about kind of taking impact and stability, and the other one is more about precise mobility. And it's a tough thing. It's you know, if somebody starts having enough other issues in their body, let's say it's in their knee or their hip, it's going to affect how they're holding their ankle and how they're striking with their feet. And given enough time, that will start like getting fully imprinted, and it won't be easily be able to get deprogrammed. So even if there's major issues here, one of the best things we can do is keep the foot pliable and happy so that it can adapt as much as possible, the foot and the ankle. And then that way at least there's something that isn't getting permanently like less efficient by other areas of the body being inefficient. That being said, if you have a problem that starts here, boy, is it a bad deal. Has anybody here had a foot injury, a bad ankle or foot? Anything? No bad ankle sprains? It's impressive. But somebody gets this stuff called turf toe. Like the bones of the toes will get jammed in a really aggressive way, let alone an ankle sprain and other stuff. But if something affects the foot and or ankle, and it's going to affect both if it causes an issue there, then it's translating the rest of the body. I mean, the clearest example is that you sprain your ankle, you have a limp, and now you're changing how you're using your entire body for locomotion, right? So, there. Structurally, the bones. We have looked at all the bones.